Neurological problems, part 2. We need to get up to slide 15. And here we are. Stroke is the third leading cause of death in the United States. 23% are recurrent. 87% are due to ischemia. $68.9 billion were spent on strokes in 2009. 67 to 85% of patients who have a stroke will survive 30 days. The cause, hypertension, diabetes, coronary artery disease, smoking, hyperlipidemia, usual causes. 30% are due to emboli, atrial fib, acute MI, or an elevated C-reactive protein, because that's an inflammatory marker, and we did talk about inflammation. Pathophysiology of a stroke, you could have a TIA, symptoms less than 24 hours, an RIND, symptoms last longer than, but there is no permanent deficit. These are considered warnings. If there is, if it occurs suddenly, it's due to an embolism. Global ischemia occurs after cardiac arrest or hypotensive episodes. Cerebral edema peaks 3 to 5 days after the injury. Complications are seizures and secondary hemorrhage. And there's a mortality of 8 to 30%. Some neuroabnormalities you'll see in a box on page 728. But they include changes in your level of consciousness that occurs with involvement of the brainstem or the cerebellum. Or you can have an increase in intracranial pressure, hypoxia, hemorrhage, and seizure. Now, if a seizure occurs, it'll do so in the first 24 hours. Now, the National Institutes of Health have a stroke scale that must be done on every patient that comes in that you think has had a stroke, and you'll find that on 728 to 731. Some of the diagnostic tests that are done, you'll have a non-contrast CT or MRI. You don't want to use contrast because if they're hemorrhagic stroke, you don't want it to go out into the brain tissue, causing seizures. An EKG, chest X-ray, or echocardiogram. CBC, E-lights, BUN, creatinine, blood sugar, and liver enzymes are done, as well as blood gases. If the CT scan is negative, they will do a lumbar puncture. Treatment, thrombolytic therapy. Now, with our TPA, there's a box on page 732 that talks about exclusion therapy. In the past, they had said there was a 3-hour time frame from the onset of symptoms. You had 3 hours in order to give TPA, which would prevent permanent brain damage. There was research in Europe that says you can go up to 4.5 hours. The dose that you give is a maximum of 90 milligrams per kilo. You give 0.9 milligrams per kilo IV push, followed by 81 milligrams per kilo as an IV drip over 60 minutes. You do not administer antiplatelets or anticoagulation therapy for 24 hours. This is different from what you do for someone who's had an acute MI. You want to keep the blood pressure below 180 over 105 to decrease any hemorrhage. And to do that, you use labetalol or nipride. If you don't give thrombolytic therapy, if the patient's hypertensive, you need to increase your cerebral perfusion pressure. You don't want to lower the blood pressure unless the systolic blood pressure is greater than 220 or the diastolic is greater than 120. You need to keep that blood sugar and the temperature normal. There's a table on page 733 that talks about blood pressure management. Your nursing diagnoses are on page 741. Your collaborative treatment and your patient education are found on page 743. Subarachnoid hemorrhage has a 25% mortality rate. It tends to affect females more than males. 85% are due to cerebral aneurysm. And there's a picture on page 735 to 6 that shows the different types of aneurysms. Risk factors for subarachnoid hemorrhage are smoking, hypertension, alcohol, and increased stimulant use. Usually, it's a saccular aneurysm that's located in the circle of Willis at the base of the brain, and there's a picture for that on 737. Aneurysms, the average age is between 50 and 60. The aneurysm can cause pressure on the optic nerve, which will result in ptosis, which is drooping of your eyelid, and ipsilateral dilatation. In other words, on the same side as the hemorrhage, they will have their pupils dilated. 10% of all causes are due to AV malformations, and the average age for an AV malformation is 20 to 40. Symptoms will be headache, change in level of consciousness, nausea, vomiting, and nuchal rigidity, or a stiff neck. The classification is on page 737. Treatment: lumbar puncture will show bloody cerebrospinal fluid. CT scan. ABCs are what you follow. Airway, breathing, circulation. Now, if it's a surgical aneurysm, they'll do that clipping within 48 hours. If it's an AV malformation treatment, the treatment's conservative. If they do surgery, they'll actually need 2 to 4 different surgeries over 6 to 12 months. Embolization may be done in the spot where surgery is not possible. There's a concept map that talks about cerebral hemorrhage on page 734. Complications in treatment: vasospasm 5 to 14 days after the injury is possible, lasting 3 to 4 weeks. Treatment is hypertensive, hypervolemic hemodilution to force the blood vessels open. So they increase the volume with fluid and volume expanders, and they keep the blood pressure around 150 to 160 systolic. They may give oral nimodidine, 60 milligrams every 4 hours for 21 days. This is a calcium channel blocker. The hyponatremia, they will occur in 10 to 43% of the cases. For this, they'll give sodium replacement and isotonic fluids. If you decrease the fluid to raise the sodium level, you have a poor outcome. So it's better to give them sodium replacement fluids with isotonic fluids. And hydrocephalus can occur in 25% of the cases. And for that, you insert a drain or a shunt. Transluminal cerebral angioplasty is your last resort. Intracerebral hemorrhage destroys cerebral tissue. Has a mortality of 35 to 52% within 1 month and 50% within 48 hours. In fact, only 20% return to functional life after 6 months. You'll have the cause is hypertension, AV malformation, aneurysm, tumor, or coagulopathy. It tends to occur more in men and more in the non-white population because they tend to be more hypertensive. Symptoms are due to a decrease in your intracranial pressure. You'll have a change in your level of consciousness, and you'll have a blood pressure of 250 over 150. Treatment: keep your mean arterial pressure below 130 if they're hypertensive. Diagnose it with a CT scan. Below 110 after surgery. And you don't allow that systolic blood pressure to drop below 90. If necessary, you give fluids and vasopressors to prevent hypotension. Treatment: ABCs, airway, breathing, circulation. Mannitol, diuretic, simple sugar. Hyperventilation, neuromuscular blockade. They may require sedation with benzodiazepines or propofol. You want to keep that cerebral perfusion pressure greater than 70. Pulmonary capillary wedge or occlusive pressure 10 to 14. Temperature less than 38.5 degrees centigrade. Surgery if they develop hydrocephalus or more than a 3 centimeter hemorrhage. They may require prophylactic anti-epileptic drugs, EPC cuffs. They keep that blood sugar at 140 or below. And as I said, the EPC cuffs. Nursing care. Assess continuously for an increase in intracranial pressure, bleeding, vasospasm, pneumonia, DVT, or pulmonary embolism. Now, to prevent the vasospasm, you control the blood pressure, put them on bed rest, keep the room dark, quiet, put them on stool softeners, and elevate that head of the bed 30 to 45 degrees. Symptoms of a bleed are hypertension, headache, nausea, vomiting, and change in respiration. Symptoms of increased intracranial pressure, change in the level of consciousness, unequal pupils, headache, projectile vomiting, and hopefully doesn't get as far as the Cushing's triad, posturing, and change in respirations. Symptoms of a vasospasm are new neurological changes. You may have damage to your non-dominant hemisphere that causes emotional lability, short attention span, poor judgment and insight, agnosia, which is a change in your spatial orientation, a change in your perception, or unilateral neglect, apraxia, which is the inability to perform learned movements voluntarily, and visual field problems, where they see only half of the field. This is called homonymous hemianopsia. Anyway, when they look out, when they close one eye, they only see half their vision in that one eye, and same with the other. So it's like they're viewing it through stripes. They can have damage to the dominant hemisphere, where you'll have a problem with speech and language. If it's affecting Wernicke's area, you'll have receptive aphasia. If it's Broca's area, you'll have expressive aphasia. If it's both, you'll have global aphasia and you're unable to communicate. They may also have agraphia, which means they're unable to write, and they'll have impaired swallowing. Guillain-Barré is a disorder that's fairly rare, but does tend to occur fairly often in this area. They think it's an IgG-mediated and cell-mediated immunity problem that results in demyelination. The infection may be the cause. It could be viral. If so, it's viral infection occurs 1 to 3 weeks before their onset, and it's usually an upper respiratory infection. Paralysis will progress starting with their toes and working their way up over hours to days. It tends to average 1 to 3 weeks and plateau for 2 to 4 weeks. And you usually have your maximum dysfunction in about 10 days, which could be as far as paralysis. Took care of a man where he could not even blink. The only way we knew he was aware of what we were saying was we had him on an EEG monitor, and we could notice his brain waves would change when we talked to him. The cerebral spinal fluid will show high protein count with normal cells. Your nerve conduction studies will be delayed. Treatment plasmapheresis costs about $4,000, and you get 4 to 6 exchanges over a 5 to 8 day period, and it's done by the Red Cross. And it's still kind of controversial. IVGGG, pardon me, can also be given in steroids. Nursing care is mainly supportive, and it may take anywhere from 2 to 48 weeks to recover, depending on how severe it is, and they may need to go to rehab. Your nursing diagnosis, patient education, and collaborative management can all be found on page 745. A craniotomy is done for tumor. And for tumor types and characteristics, you're supposed to see page 746. And there's a figure on 747 and 748 that talks about the different operative terms that are used. Now, preoperatively, you need to attain CBC, blood BUN, creatinine, fasting blood sugar, chest x-ray, EKG, and type and screen. Some of the possible complications are diabetes insipidus, and this will occur because of a decrease in ADH, your antidiuretic hormone. This is usually self-limiting, but they will have like 200 milliliters an hour out as a result. They may also have SIADH due to an increase in your ADH secretion, where the body will save water but dump sodium. This also is usually self-limiting. You may have a cerebral spinal fluid leak, and you can tell that if their glucose, when you check the CSF, it has a glucose of 30 milligrams per deciliter or greater. If that occurs, elevate the head of the bed and keep your patient on bed rest. DVT, stress ulcers, pneumonia are also possible complications. Nursing care promotes adequate cerebral perfusion. You want to elevate that head of the bed by 30 to 45 degrees. Keep the head neutral and have no hip flexion. Fluids, intake and output, and you check their specific gravity to make sure they're getting sufficient fluids. You will have them on a fluid restriction if they do have SIADH or cerebral edema. You want to control the nausea and the vomiting. Early nutrition, tube feedings, control the fever by using cooling blankets or Tylenol. You want to prevent infection. prevent injury, such as corneal abrasions. You use saline drops and or a polyethylene film to prevent that. You want to prevent a DVT, and your evidence-based practice for that is on page 750 to 751. Your nursing diagnoses and patient education you'll find on 752. Early rehab is very important. Adequate arterial oxygenation, so you suction and you prevent pneumonia. Comfort and emotional support. You don't want them constipated, because if they strain to have a bowel movement, that's going to increase intracranial pressure. So you get an order for stool softeners. Increase the fiber in their diet, increase their fluids in their diet. Pain management with morphine and then codeine, but remember, it causes constipation. And there is a new drug out there that you can give for patients who are constipated due to opioids, but it's better to increase the fiber and the fluids in their diet. Intracranial hypertension, it means you have an ICP of greater than 15, because your normal ICP is less than 15, normally. There's a table on page 753 for causes of increased ICP. To get your CPP, your cerebral perfusion pressure, you need to find out your mean arterial pressure, and then you subtract from it your intracranial pressure. And it's best if it's around 80 in this instance. If it's below 30, you have ischemia, hypoxia, and cell death. When it equals your ICP, you have no cerebral blood flow. And if your mean arterial pressure is between 50 and 150, you have adequate cerebral blood flow. If your PaCO2 drops below 20, the brain will become ischemic. Acidosis will increase vasodilatation, and alkalosis decreases vasodilatation. A decrease in your BMR will decrease cerebral blood flow. Now keep in mind that your brain uses 15% of the oxygen and 20% of your cardiac output normally. There's a concept map on page 756 that details intracranial hypertension and how to treat it. And there's a figure on 758 for the sites for ICP monitoring, that will also have a picture of a ventriculostomy there. A ventriculostomy is sometimes called a brain drain. It's a tube that's inserted for ICP monitoring. It's done at the bedside, and it's left in for 3 to 5 days. There are boxes on page 754 that show how to decrease cerebral edema and increase cerebral perfusion. Collaborative management is on page 759. Your therapeutic management is you want to manage your temperature. Keep that well controlled. Temperature between 33.5 and 34.5 degrees centigrade. If not, they can develop dysrhythmias. For every degree Celsius of elevation, cerebral metabolism increases 7%. Blood pressure control is important, and there's a figure on page 778 for that. You want to keep it in the high normal range. You treat it with sedation, and you use care, as you don't want them to vasodilate. Seizure control is essential, and you control this with dilantin and phenobarb, with lorazepam for breakthrough seizures. You want to decrease that intracranial pressure because your goal is to prevent herniation. So you use osmotic diuretics such as mannitol. This will increase perfusion to the ischemic areas, causing cerebral vasoconstriction and decreased ICP. You have to check your CVP. Oftentimes they'll also administer loop diuretics such as Lasix. Fluids have to be managed, as dehydration would decrease cerebral perfusion, and that's why you have a CVP in place. You need to decrease the metabolic demand by administering barbiturates, which decrease free radicals, decrease the blood pressure, lower blood to areas of decreased flow, shunt blood to areas of decreased flow or damage. They decrease oxygen demand to the brain. They have to be tapered. Complications are hypotension, hypothermia, and myocardial depression. Some of the medications that are used are on page 760 to 761. And that finishes this part of the lecture.